Dr. Constantinidou will present the ENDO test and first and foremost the premenopausal data.
Thank you, Peter, for the kind introduction. Good afternoon to everyone in the audience. It is a pleasure to present and discuss the results of our clinical validation study of ENDO in premenopausal women with ER-positive, HER2-negative primary breast cancer. So a little bit about the background of the study. In terms of patient population, the cohort comprised 385 women with premenopausal ER-positive, HER2-negative breast cancer. These patients were taken from two different centers, from the BOC Oncology Center in Cyprus and the University Nottingham Hospitals in the UK. In terms of the nodal status and the size of the tumor, these patients had an N0 or N1 disease, and they had a size of disease of up to T3. They all received endocrine therapy only. It is critical to say here that these decisions were made several decades ago. This is a long follow-up study for these patients, and so they were based primarily on clinical pathological features and clinical judgment. The primary objective of this study was to evaluate the association between the EP-clean risk score and the 10-year distant recurrence. In terms of the analysis, formalin-fixed paraffin-embedded samples were retrieved from the biobanks of the two centers, and they were retrospectively tested with ENDO. The association with distant recurrence-free survival was evaluated by Cox proportional hazard models, and the 10-year distant recurrence-free survival was estimated by Kaplan-Meier analysis. Here are the patient characteristics. So a total of 385 patients. The median follow-up time in years was 9.7. The mean age at diagnosis was 46.5. The mean tumor size was 1.6 centimeters. The majority of the patients had grade 2 disease. The majority of the patients had node-negative disease. 62 out of the total number of patients had node-positive disease. The mean Ki-67 expression was 14.7. The mean ER expression was 83.4. The mean PR expression was 78.5. And when it came to the results, the majority of these patients in the entire cohort had an EP-clean low risk. That was a 65%, with the remaining having high risk. Of note, just over half of the population had received ovarian function suppression. So in the univariate analysis for distant recurrence, both the EP-clean and the EP scores were strongly associated with increased risk of distant recurrence, and this remained significant for both in node-negative and node-positive patients. In the multivariate analysis for distant recurrence, the EP-clean score was the only factor significantly associated with the risk of distant recurrence within 10 years. And with regards to other parameters, the EP molecular score, but also perhaps as expected, the tumor size, the nodal status, and indeed the tumor grade were all associated with distant recurrence. Now, here are the results. This is the main outcome for all patients included in this cohort. The 10-year risk by EP-clean risk score, 65% of the patients were classified as EP-clean low risk. You can see that on the top green curve on your graph. The EP-clean low risk group had a significantly lower risk of distant recurrence. That was 3% here compared to the high risk group. All patients, I remind everybody, did not receive chemotherapy. When it came to the type of endocrine therapy they received, 42% of the patients received tamoxifen. Just over half of the patients received tamoxifen in combination with ovarian function suppression. Now, looking at the specific subgroups, so the node-negative population, which was the large subpopulation of the study with 323 patients, 73% of these patients were classified as EP clean low risk, and this population had a significantly lower rate of recurrence compared to the high-risk group, both obviously without chemotherapy. So let me move on to start the roundtable discussion by presenting actually the first of our three cases, which is a case of a node-negative disease. This is really to highlight the significance and the role of the gene expression testing. So this is a case of a 49-year-old woman who was premenopausal at presentation. She had invasive ductal carcinoma that was grade 2. The ER was 83%, the PR was 83%, the HER2 status was negative. The Ki67 was 10%. The tumor size was 16 millimeters, the nodal status was negative, and the patient received mastectomy and axillary node clearance. Let me note here that this is a cohort of patients that was treated between 2003 and 2016. So in some of these cases, we do indeed see much more aggressive treatment when it comes to surgery and perhaps to chemotherapy based on the fact these were treated quite a few years ago. This woman was treated in 2004. Shall I say that based on the clinical pathological features, what was done is that this patient was treated with tamoxifen for 5 years and ovarian function suppression. She was followed up for 15 years and there was no recurrence. So this was done based on clinical judgment, and here we come many years later to retrospectively perform an ENDO-PREDICT test on this woman, and the result is what you see on your screen. So the EP clean score shows a high risk for recurrence. The likelihood of distant recurrence after the patient receives 5 years of endocrine therapy alone is 20%. The absolute chemotherapy benefit was calculated to be 8%, and the likelihood of late distant recurrence within years 5 to 15 was calculated at 15%. I will pause here, hand over to Peter, and start the discussion. Oh, yeah.
So, perimenopausal, very young woman, intact menstrual cycles, 49 years old. She's a 16 millimeter nodal, 10% Ki67. I mean, the first question we need to ask, despite the fact we're eating Myriad's food here, do we need a test in this patient? Can I just ask you, and maybe ask the audience, how many of you would actually order a genetic test in that woman? Comment on it.
I don't know if it's functioning. It's working or not? Yeah, it's working. To be honest, I'm not sure that I had performed a test in this situation. 49 years old, 16 millimeters, Ki67 at 10%, luminal A. It's quite a surprise for me, but I know the recommendation of NCCN, but at that time, even a few years ago, I will treat with endocrine therapy without any chemo, without any doubt at that time.
Thank you. Michael.
This is a retrospective study which you presented.
Yep.
Very nice outcome data, long-term follow-up, which is very important to know. Because recurrence and metastasis does not stop at 5 years, as we know. So it's a very important piece of information. Number 2, Peter, we are acting with the knowledge of today. So EndoPredict in my country is reimbursed by the Krankenkassen, by the insurance companies in this situation, especially in the node-negative premenopausal patients. There was and still is an insecurity, even in the G2, small tumor, hormone receptor positive, HER2 negative situation. So this test is giving us a reassurance how the prognosis this patient is. And the better the prognosis, the less chemotherapy indication we have. And on the other hand, and we are going to come to that point later on, the higher the recurrence score is, the higher the risk of metastasis is, the more benefit she would get from chemotherapy. But we might take some time later on, Peter, to discuss the topic of the combination of aromatase inhibitor with ovarian function suppression instead of chemotherapy, which is a very interesting topic.
So I totally agree. Obviously, we're looking at patients that were treated 15, 20, 25 years ago based on clinical pathological parameters only. We did not have the benefit of genetic sort of expression testing at the time. What this case proves is that based on that grade 2 and the T1C, back then the clinical judgment was to proceed with endocrine therapy and ovarian function suppression. We do have the ASCO recommendation of 2022 actually suggesting that perhaps in this high-risk premenopausal population, we should be considering chemotherapy or endocrine therapy with ovarian function suppression. Perhaps the reason this woman never recurred was because she did receive ovarian function suppression. With today's standards, perhaps we would feel ovarian function suppression to be slightly on the top, perhaps a bit more than we would have done in routine clinical practice. But this is knowledge of today. We didn't have it back then.
Agreed. So for those less familiar with EndoPredict, this is a test you can perform locally in a very short time with a fairly simple technology. I mean, even a surgeon could do this. And in your pathology department, this will actually not cost a great deal of money. So that's one thing. Could I just get a sense from the audience, when you look at this particular case and you discuss it in your tumor board, would you consider gene expression testing? Doesn't have to be Myriad, can be anything else. Would you, or let's say, would you test? And the next question is, would you consider testing? Would your patient have a gene expression test in your tumor board in this? Can I just, the yes, hands up? Okay, you can't see it, I can. There are very few people here that would actually consider genetic testing in this particular patient. Can I continue with this particular case? And let's say you have this case, but she has a Ki67 of, let's say, 25%. Let's not say 30%, okay? But it's clearly elevated. Can I have another show of hands? Would you be more interested in the gene expression test now? Show of hands now. Yes. So this is what I thought.
Can I add a comment?
No, you can't. Yeah, no, please, go.
I'm absolutely sure that you have the best pathologist in the world in your institution. Period. But what is the threshold of Ki67 between pathology institutions? This is not a bashing of pathologists. What I'm saying is that we know that the threshold can be as high as 30% of the value you are receiving. And then suddenly from 10 you get to 18 maybe, or maybe from 25 you get to 15. And therefore Ki67 is an excellent, very old marker from 1986. But I think in the era of multi-gene assays, we could use more multi-gene assays.
I do have a comment, if I may. So the thing that happened here is that Clearly, we may have the best pathology in the world, we may do, but what we did have for sure is the same team of pathologists and the same team of oncologists throughout the period of 2003 and 2016. It's not the absolute number of the Ki-67, is the difference in the fact that these people were reporting consistently the same way, which then gave the oncologists the same level on which they had to judge. That was, I think, the key.
Thank you. Are there any questions from the audience considering the young premenopausal patients? Anything that you would come up with at this point? So, really, really interesting case. Sort of a discordant result that we're seeing here, right? First session on clinics is, oh, forget it, and then all of a sudden a higher risk in your multi-gene test. Very difficult to deal with.
Yep.
Continue with this?
Let's continue,
I think it's a node positive case next, so just go on.
Okay, so moving on to the results regarding the node-positive patients admittedly. This was a small sample. This was 62 patients. So 19% of the node-positive, premenopausal, ER-positive, HER2-negative patients were classified as EP-clean low risk. This risk had a distant recurrence rate of 0. So none of these patients recurred over the long period of follow-up. And compared to the high-risk group, there's clearly a significant difference. So looking at a node-positive case, this is a 39-year-old woman who was premenopausal at presentation. She did have invasive ductal carcinoma. She had a grade 1 tumor, an ER of 83%, a PR of 100%, a HER2 negative expression. The Ki-67 here was 5%. There were 2 tumors in 2 different quadras. This was a 10 millimeter and a 12 millimeter tumors. The nodal status was positive, so 1 out of 9 lymph nodes. This was reported as having a mastectomy and perhaps a partial axillary lymph node clearance. I remind everybody these are much older times compared to today. So how was this patient treated? This patient also received tamoxifen for 5 years and ovarian function suppression. She was followed up, has been followed up for 7 years. And there has been no recurrence. So that was the way it was managed back then. This is actually one of the latest patients in the cohort, treated in 2014, 2015. And this is what the outcome of the EP-clean score was. This was reported as being low risk with an absolute level of 3.1. The likelihood of distant recurrence was calculated at 8%, the absolute chemotherapy benefit at 2%, and the likelihood of late distant recurrence at 6%. Another controversial case.
Thank you. This case makes me much happier because it's such a beautiful de-escalation case, right?
Yeah.
I'm going to ask the audience again. This is not just young. 39 is very young, node-positive, nice biology patient. How many of you would consider doing a gene expression test in that patient? Come on, don't be shy. It's free. Let's say it's free, okay? You can do it. Much more than in the last one. Okay, thank you. How many of your node-positive, premenopausal patients, ER-positive, have chemotherapy, Michael? Just on top of your head, would you say?
Without having a multi-gene assay in place?
Just in broad general terms, and then
Europe,
when you
Germany, Eastern Europe, Western Europe,
Berlin,
US, Canada.
Berlin.
At least 50%.
Yeah. Could you comment on your own rate of using gene expression tests in these patients?
So number one, dear Peter, a 49-year-old lady is still very young, not just a 39. Okay, we agree on that?
The reason, okay,
Do not comment that.
you know, I've reached the 52
Okay.
now, but
No,
but let me make a comment because I think it's very important. I'm starting to think about the young ages in different groups, and if you look at some of the genetic sequencing data rather than the genetic expression data, between women around their 50s and 60s, so clearly postmenopausal, and then 40 to 50s and below 40, then in some of the mutations and recurring gain-of-function mutations we're seeing is that in these very young patients, you really not only have quantitative differences towards the old, but you actually have qualitative differences, meaning there is some biology going on and that's why I say very young versus not so young. And maybe we should stop with young and old, just say those below 40 and those above 40. So that's the comment I'm making, and that's important to realize as we apply gene expression tests. I'm sorry, it's a long answer.
But again, to comment on the case and on the situation of these patients, I think one of the really powers of this multi-gene assay is not just the prediction of the first 5 years, but a prediction of long-term outcome. And if you really see the literature on this test, you are going to be convinced more and more. And I mean, you're a pioneer of some of the works with this test. And as you know, that is really something very important because, again, recurrence and metastasis, especially in those young patients, do not stop at 5 years.
Sure.
So that is so important to have long-term outcome data in order to decide now what to give to the patient and what maybe to spare. And to spare chemotherapy from this patient means that you really need a secure, a reliable test to really spare her from chemotherapy. This is the major bottom. So everybody's talking about de-escalation. I totally agree. We have overdone it when the National Consensus Conference in the 90s in US said every node-negative patient should receive adjuvant chemotherapy. Now those times are over. So, you know, our colleagues from America, the pendulum is going from one side to the other extreme, I have the impression. Here in Europe, we are a little bit more, you know, long-term, I would not say conservative, long-term oriented. And this lady wants to know from me, when she sits in front of me, am I going to survive my cancer, period.
Can I just make a very quick comment about especially premenopausal women, ER-responsive disease and chemotherapy? I think it really depends on what your tradition of adjuvant treatment is. And with tradition is something that is very unscientific, I realize that. But for example, most of my medical life and formation was built in Vienna. In Vienna, we had premenopausal trials where we were including premenopausal women, including node-positive disease, into endocrine therapy trials without chemotherapy. And it was only when I was in the States for the first time that I realized people were looking at me going, are you mad? Are you Austrians absolutely mad? You have these large ABCSG12 trial and none of these patients, or 5% of these patients, had chemotherapy. So I think it's important to realize where is your tumor board, wherever you're coming from, how important is chemotherapy? And that's, I think, also how you would dictate on how to use a genetic expression test. And I've stopped you, so go ahead. I'm sorry.
Sure, thank you. So I would make another brief comment. Clearly, when it comes to premenopausal patients, we're all quite concerned because especially in the ER positive HER2 negative subtype, we do know that if they are diagnosed under the age of 40, they run a much higher risk. The mortality rate is over double the mortality rate of the diagnosis after the age of 50. And therefore, we are concerned about these women. We do want to provide the best possible treatment. And if they are node positive, yes, many of them will have to receive chemotherapy. But I guess the message from this case is that there is still a good percentage of these women, and about 20% percentage in our study, that can forego chemotherapy and they can be absolutely safe.
I think we're all clear on that. I mean, in a population like that, if you would say, I'm giving them 6 times TC, your number needed to treat would be, what, 25 to 30, which means if we had the perfect biomarker, we could de-escalate in more than 80%. We need to be aware of that.
Yet, however...
In the perfect world, you know...
Yeah, but yet, however, the ASCO 22 guideline for premenopausal women says treat all with chemotherapy. So we just need to be able to extract those patients, might be a small percentage in the node-positive disease, that do not need chemotherapy.
I'm just going on with your slides. You have some more data to show us after this?
So it's another case, yep.
Yes.
So data and case.
Before we go back to data and case, we're fine in time. Please go, use the microphones, ask us questions, bring your own cases, okay? It's fine, this can be interactive. Just finish what you're eating before, thanks.
Thank you, thanks. So this is the last part we're highlighting from this study, the association with ovarian function suppression. So over half of these women had received ovarian function suppression. I remind everybody this was based on clinical judgment. But look at the graphs. So on the left-hand side, there's patients who received ovarian function suppression. On the right-hand side, patients who did not. And there was a similar 10-year distant recurrence-free survival rates in patients with low risk, low EPI clean scores, who received ovarian function suppression treatment, and those who did not. Obviously suggesting that if our patients are truly low risk, as defined by ENDO predict, then they do not need ovarian function suppression. And here's a woman that is 42 years old. She's premenopausal. She had invasive ductal carcinoma, grade 2, ER 73%, PR 100%, HER2 negative. The Ki67 here was 15%. It was a small tumor size at 7 millimeters, and it was node negative disease. Again, this patient was treated towards the end of the cohort. She had a lumpectomy, a sentinel node biopsy, and she received tamoxifen for 5 years. And after 5 years of follow-up, there was no recurrence. What did the retrospective ENDO predict score show? This woman had a low risk of recurrence and a 0 benefit, actually, from chemotherapy. That's what it said.
In many ways, a very similar case on that. Louis, you've been quiet. Go ahead.
Yeah. I think the results are very interesting about the ovarian suppression. In the case of the low risk, in agreement with the soft context studies, there are no need to add the ovarian function. It's adding quite nothing. Yeah. For the high risk is not the purpose of the study. It will be interesting to see because the discussion in TLRX, MANDACT, and so on, it's what the part of the chemo, what the part of ovarian function can we replace, and so on and so on. It will be interesting to see if in the high-risk population, the ovarian function is doing something or not, comparing both, but it's with the size of the study, that could be difficult, but that's a more tricky point. Reassuring for the low risk and for the high risk, ovarian function or not. Is it sufficient or not? That's the point.
Michael, you're itching. Go ahead.
So, first of all, Anastasia, congratulations to this paper. Really, it's great. Although it is retrospective, although it's not randomized, but by chance, you have 50% patients with ovarian function suppression, 50% without ovarian function suppression, and you clearly show that you have a very good effect. So, data which have been presented by my colleague Nadia Habeck yesterday, by Oleg Lutz yesterday. Oh, that was a great comment in the discussion by you, Peter. Fantastic. So, we have data from Germany showing that at least that neoadjuvant treatment, like 2 to 4 weeks, with ovarian function suppression and aromatase inhibitor compared just to tamoxifen, the Ki-67 drop is tremendously different. So that gives the very same piece of information on the hypothesis, which you just said, that a large effect of chemotherapy in premenopause is the chemotherapy-induced ovarian function suppression. So why not just give them OFS and AI instead of giving them chemotherapy? And this is increasingly what I'm doing in my all-day clinical work. If the patient comes and said, oh, I entered to the Google or those predictive machines from Oxford and so on, and my risk is 6% less absolute risk with adding chemotherapy, and she says, well, but I don't want to take chemotherapy. I say, okay, then you have to take at least the side effects of ovarian function suppression, but that is something which is probably a very good alternative instead of chemotherapy. I'm not talking about very high-risk breast cancer patients with 4 lymph nodes, because I see patients, they come with 4 lymph nodes, somebody is doing a multi-gene assay, even in 4 and plus lymph nodes, there is no evidence to do so because the risk is so high that you cannot, assess it or diminuate it or make it smaller with a multi-gene assay. So multi-gene assay, node negative, clear. In 1 to 3 lymph node, also clear.
Just a clinical observation from my side. I do something very similar in my clinic, and especially in Switzerland, there are a lot of women that really do not want to go under chemotherapy for many, many reasons. But my experience is that many of these women, where we discuss this, and in the end we decide, no, let's not do chemotherapy, but let's try ovarian function suppression. A lot of that same group of women drop the ovarian function suppression within 3 months because they just can't take the side effects. And then you end up with tamoxifen alone, and simply statistically speaking, that is clearly undertreating these women. So it's really, as you go back into your clinics and have these conversations and make these shared decisions, keep in mind a lot of the women that are not going to be into chemo very much are a group that is also going to drop the ovarian function suppression quite quickly. So don't go easy into this.
Okay.
I'm going to let you finish, and yeah, we're doing fine.
Thank you. So, to conclude, with a median follow-up of 9.7 years, the EP-Clean risk score and EP12 gene molecular score were prognostic for 10-year distant recurrence in premenopausal women who received adjuvant endocrine therapy alone. The ENDO-Predict identified 65% of premenopausal patients with a 10-year distant recurrence of less than 4% who safely avoided adjuvant chemotherapy, and that was independent of the nodal status. 73% of patients with node-negative disease and 19% of patients with node-positive disease were identified as low risk by EP-Clean score. Similar 10-year distant recurrence-free survival rates in patients with low-risk EP-Clean scores who received ovarian function suppression treatment and those who did not. These results support the use of ENDO-Predict for all women with early-stage ER-positive, HER2-negative localized breast cancer, regardless of the menopausal status. Thank you.
Thank you so much. I can't stress enough how important it is to have nice genomic data on premenopausal women. The message that I'd like all of you to take away from this, as you go home to your tumor boards, think on how you want to use biomarkers in our younger patients, and as you consider chemotherapy, how do you combine them? Are you going to use a dynamic Ki-67? Are you going to use a gene expression test? And if you decide on these things, make sure that you have a rule in your tumor board saying, who are the patients that need the test? Who are the patients that don't need the test? That's okay too, okay? And who are the patients that are clear chemotherapy candidates? It's not so hard, but you need to write it down and come to rules about it.